the planning letter for the coming winter at the end of July. It is the earliest winter letter we've ever had as an NHS, which does allow us to get the preparation work in place there. One of the other things that included was what I refer to as job cards for each part of the system. It's been really clear about the accountabilities of organisations like ours, but also being clear that system working involves accountability in all parts. So there's a job card for primary care, for mental health services. And what I've included there are the elements of the job card for acute providers such as us. And the first two items on there actually are really fundamental. That same day emergency care model that ensures that we don't admit patients unless we need to, and frailty. A huge proportion of our admissions are patients who are admitted as emergencies who are over age 75 and therefore can have issues relating to frailty. So making sure we've got the right services that firstly support those individuals at home and ideally avoid admission, but then when they come into hospital, starts their assessment really early on and ensures the full MDT are involved in that. So we'll be doing quite a bit of work on that. Some good examples, some work elsewhere in the group, and we'll be sharing and learning from those. There's a capital incentive linked to UEC performance this year, which I referenced there. I also referenced the NHS workforce plan. It's been around a few months now, linked to a 2.4 billion funding announcement. I think it's still fair to say it's not entirely clear how much of that 2.4 billion is additional funding, how much of it assumes some productivity improvements. But nonetheless, we've been waiting for a workforce plan for a little while now, so it's good to see one there. Included within that are some additional training places for a range of disciplines, but particularly for us, it's good to see some additional doctor training programs, which should support the Three Counties Medical School, which is on our doorstep. Some changes to fit and proper person test, which I reference, and in future board meetings, we'll get into a pattern of having a little bit of a drill down into one function within the trust, and I'll include those from next month on. So I'm happy to take any questions on any of that, Chairman.
That's great. Thank you, Glenn. Questions or perspectives to Glenn? Simon?
Thanks, Richard. Thanks, Glenn. In your report on page 15, the second paragraph, where you said the majority of flow problems in our system are within the acute setting, totally agree with that. I think probably it might be helpful just to point out that the causes of those flow problems aren't caused by the acute setting as well. You might read it to think that it's a problem that's created in acute, whereas we know it's across the whole trust. And to a lesser extent, some of our external partners. So it's just to put that on the record as well. And then I think you mentioned something called Operation Ring Fence, which I should know what it is, but I don't. And if you could let me know, that would be helpful. Thanks.
Yeah, when I refer to the acute setting, what I'm referring to there actually is within the acute hospital as opposed to in community services. So the majority are within the acute hospital. Actually less so, as we discussed earlier, around the way that our A&E works, but more so around the interaction between the A&E, some of our medical assessment areas and the kind of individual specialty wards. And we'll talk a lot more about that in future meetings. In terms of Operation Ring Fence, this was an initiative across the group, which we put in place about 18 months ago, which is fundamentally to ensure that we don't cancel elective patients. And that's fundamentally in the past been related to the use of elective beds by emergency patients when hospitals overheat. Now, that's not good for those patients because you end up putting an emergency patient into an elective ward and they don't get the best care. They're better off in the right subspecialty. But equally, that also then leads to the cancellation of elective work, which for many of our patients who waited longer than they should have done already for their surgery, that's something we really need to avoid. There's also a relationship between having long waiting times for elective work and unnecessary attendances at A&E. So it's a virtuous circle to try and protect your elective activity, do that work, don't cancel those patients, but also fundamentally to treat our emergency patients in the right teams, in the right part of the hospital and get them home as quickly as possible. So we'll definitely be, I mean, there's already some excellent practice across this trust, don't get me wrong, but every trust in the land can continue to make improvements in the way that it manages flow, and we'll always have that attitude.
Yeah, I think there's no doubt, Glenn, even since arrival, we've seen some pockets of really great performance in some of our divisions. It's about making all of our divisions rise to that standard, but I think it's undeniable that the biggest opportunity and challenge we've got is around making sure patients flow quickly out of the ED through the acute setting and then are discharged as quickly and as safely as possible. Because, as I said earlier, the evidence for hospital-acquired functional decline is very substantial. And literally every day we keep someone in hospital when they're better off at home, we're actually harming them to an extent. And I can see nodding heads around the digital room in that regard. Any other questions or perspectives, or are colleagues happy to move on? Okay, we'll move on then to Richard's report on communications and engagement. Richard, over to you.
Thanks, Chair. This is the regular quarterly update on communications and engagement. I'll take the paper as read and just pick out a couple of highlights, if that's okay. We've spent and will spend today a lot of time talking about the new ED development at Worcester, so it's worth saying thank you to everybody who so generously supported the fundraising appeal to put the finishing touches to that unit. The first time that we tried some of those approaches through the charity, and I think very, very heartened by the response of the public, and great to see that over the weekend we have started on some of the external artwork on the new ED site, just as one of the environmental enhancements. I would encourage colleagues, if they haven't already, to catch up on the piece on the BBC Morning Show about our use of virtual reality headsets, which are proving very popular as part of an initiative that we did in partnership with the CoLab and our system partners. Glenn's already touched on Rumour Mill, and it is proving a very popular service, not just for people who want to ask questions about parking, but about colleagues who want to raise issues about a wide variety of subjects. I think it's fair to say that it is something that the comms team is going to have to get used to managing in amongst their many and varied other responsibilities. But we've had generally a very positive response to that. And then one thing that isn't in the report, but worth saying a thank you again from a charity point of view to everybody who supported the Trust charity running in the Worcester City Run over the weekend. It's our second year as headline sponsor, and the early signs are that even after all the costs are set off, we should get another £6,000 or £7,000 for Trust for the charity, which is very good, as well as being a good profile raiser. And then looking ahead, Culture Month starts in October, where with the help of our Freedom to Speak Up network, Forward Advocates and staff engagement networks, we're looking forward to a month of celebration about the staff engagement and support, and celebrating some of the success of those groups. And then through the rest of this year, moving ahead to moving the internet to a new content management system, and then moving ahead with a redesign of the Trust intranet, and a move hopefully over to a SharePoint system, which should make it more user-friendly for people looking for information to support Rumour Mill, and also easier for us to support teams and departments across the Trust to build an improved intranet presence within the Trust. Leave it there, Chair, but happy to take any questions.
That's great. Thank you, Richard. Questions or perspectives to Richard? Well, Richard sort of mentioned the Rumour Mill, and as Glenn indicated in his report, the Rumour Mill is great at being able to anonymously raise issues, and the whole issue of freedom to speak up is incredibly important generally, but particularly with the next topic we're going to get on to is disproportionately important. And I would just like to make a general point. All members of staff who work at Worcester Acute, at any point you can reach out to me. My personal email is russell.hardy2909@icloud.com. If you've got any issue to be concerned about patient safety or bullying or harassment or misogyny or any other aspect which you're concerned about, the board are here to help, and the board want to hear your concerns. And when it comes to the topic of Lucy Letby, it's incredibly important for us to be able to assure all of our citizens about the processes we have in place to minimise the risk of an act of evil being done within our premises or by a member of our staff. So, Sarah, over to you.
Thank you, Russell. So the paper that you have in front of you is our trust response to the NHSE letter, which we received on the 18th of August following the conviction of Lucy Letby. And NHS England asked trust boards to consider and rapidly review 5 points. And the paper outlines our assurance and the processes that we have in place within the trust. And just to add is that we robustly discussed this paper in detail at our Quality Governance Committee. So I wasn't going to go through it in great detail now, but happy to ask questions. Just a few points just to pull out. I think we do have strong governance processes in place. And although we really need to consider that regardless of systems and processes, people who wish to cause harm will always try and work around the processes that are in place. And it really is looking at our intuition, it's looking at the near misses and really being alert to prevent or for early identification of concerns within the trust. And what we've asked all of our staff to do is to consider, could this happen here, analogy. And also, which we've already touched on in Glenn's report, that this is applicable to the whole trust, not just maternity and neonates. So the learning that has already come out through the trial, that issues were identified such as gaslighting, and this is that it was felt that Lucy got away with her campaign of violence for so long because people just couldn't contemplate that a nurse was trying to kill babies. It was just too difficult to imagine. The second point was that hospital bosses failed to investigate the allegations and tried to silence doctors, and that the hospital delayed calling the police despite months of warning that the nurse may have been killing. The hospital's being accused of trying to protect the reputation and putting that before babies' safety, and that Lucy was allowed to continue to work in a clinical area whilst these concerns were raised, and then moved into a patient safety role where has access to all of the information that was being used in order to investigate the allegations that were made. And deaths were not appropriately recorded or looked into, which again is a matter of concern. So the paper, as we've laid it out, is that we have covered all of the 5 aspects, and there's just a couple of things that I do want to just pull out on. So the first is around all of the processes that we have in place and all of the avenues that staff can talk to us. And I have to say, from my point of view, sort of 10 weeks into post, I have had staff come and talk to me where they feel that maybe they've not been listened to or their concerns acted upon, which for me, I feel that's quite positive, that they do feel able to come and speak, to executives, and it's promoting, as Russell's just done, that we absolutely do want that to continue to happen. We do have our staff networks. We do have our Freedom to Speak Up guardians and champions, which work across the trust. And within our safeguarding training, we do specifically talk about gaslighting, and there are case studies within that training to get staff to understand, to look for all eventualities. We also have the managing allegations policy, and also the a policy around what to do if people are concerned, and that people who are in a position of trust, having access to patients or children, the processes that they can follow, which means that immediately the police would be involved in assessing any allegations, which obviously would have helped in the Letby case. And lastly, from a assurance point of view to the board, back in 2016, it was identified by the division that they'd had an increase in the number of stillbirths and neonatal and maternal deaths. And the division commissioned a thematic review of all deaths, and that there wasn't found to be any trends or causes for concern, but it was identified, it was acted on appropriately. And also the second point is that on the sharing of the Lucy Letby case in October 22, the CNO at the time did request a review of medicines management in the neonatal unit. And at this time, the trust lead did find excellent compliance with the management of medicine. So again, prompt action was taken. We've also got the medical examiner role, which is well embedded within the organisation. And we also have robust governance around our safeguarding and the board oversight around any concerns around people in position of trust. So I will stop there, Russell, but happy to take any questions.
No, very helpful. Thank you, Sarah. Just before I open up to questions or perspectives, Julia, as chair of our Quality Assurance Committee, any comments you'd like to make in terms of this report and Sarah's summary?
I think Sarah's given a very good account of it. Thank you. What I will say is that the trust, when I first arrived, did not have the medical examiner role embedded, and that was a risk. It's now been sorted and we have got them. So every desk should be reviewed. Sometimes it's not as timely as we'd like. I think one of my observations about this, when I've reflected a lot upon it and reading this report, is there are huge parallels with Ian Patterson. Clinicians raised concerns and they were ignored. And in fact, those clinicians who raised concerns were dealt with quite harshly. They were told they would have their own practice looked at, and all kinds of stuff went on. And it's the same thing again. So we have to listen when people raise concerns, and it has to be investigated properly. That's what I would say. So I think we haven't learnt from Patterson, or the Countess of Chester didn't learn from Patterson, and we need to be really careful that we do. We did go through it very thoroughly. One of my concerns is we don't start calling this the Letby report as well. We don't start immortalising her. We talk about the safety and care of our patients, but not immortalise a murderer.
Absolutely. And it's worthwhile just reiterating that the Freedom to Speak Up role didn't exist in 2015 when these incidents occurred, and it came in 2016. Questions and perspectives, Karen?
Thank you. Thanks for the report, Sarah. Really comprehensive and assuring. And certainly, I would say that as the non-executive Freedom to Speak Up lead, I see around the organisations what you've said, the awareness, the support, and all of that is in place. So in terms of that process itself, I don't have any concerns. My question is more about correlation with things. So in visits and talks and walkabouts, I've heard on a couple of occasions comments made about how people wait an awful long time for feedback or even indeed any action in response to DATIC's reporting. And I wonder, how can we correlate those things, and should we be worried about that? Is that something that's on your radar, or what would be your perspective on that, around that? Thank you.
Sarah?
Thanks. Shall I respond? Yeah. Thanks, Karen. I absolutely share your view around the DATICs and the feedback. And that's something I've picked up on my visit. So we are just in the process of looking at our quality boards for each of our ward and clinical areas, which will cover some of that feedback. But there's also something about the daily huddles. And we went over to another trust who does this very well, where feedback is given daily on the incidents raised and the concerns raised from the day before. and they have a really good process that we are going to steal with pride. So we're looking at the beginning of October that we'll have that in place across all clinical areas.
That's great, thank you.
Thanks, Karen. Thank you, Sarah. Any other questions or perspectives? I would just like to commend all of our midwifery and paediatric teams who day in day out give wonderful service to the citizens of Worcestershire, and I wouldn't want them to be tainted by the evil done by this one individual. That they do go to phenomenal efforts to make sure that a baby is delivered safely, that mums are safe as well, and that happy families are the result. So I just want to put that on to the public record. So it was touched on earlier by Glenn and Richard, which is our new UEC centre. Helen, over to you.
Oh, sorry, thank you. Thank you, Chair. I'll take the paper as read, as always, but I wanted to pick out a few key issues. As the board will know, we had a workshop this morning to discuss our readiness and our preparedness to open our new ED. I think, and the paper sets out the history behind the new ED building. I think it is important for the board to be aware that the ED itself, the opening of the new ED, whilst it is an excellent environment and a much nicer environment for patients in terms of privacy and dignity, and also for supporting the working environment for all the staff within the ED. It is the rest of the organisation that needs to support and improve flow through the organisation. So the ED itself, whilst that will be opening and is lovely and environmentally lovely, it will not solve all of the challenges that Worcester has. So as you will see in the paper, we had a proposed go live date for the 2nd of October, and the paper sets out all of the actions that will have been taken place or about to take place for the 2nd of October opening. However, with the announcement of the industrial action and the joint industrial action between the junior doctors and our consultants, it was felt that going live during the 2nd of October was a clinical risk to the organisation. Mainly because we would need to run across the sites, we'd need to have 3 EDs open at any one time, which would mean that increased numbers of staff, but also not within the ED, but also within the whole of the organisation. And that was felt to be too risky. And so we're seeking approval then with the board to move the date to the 16th of October, as discussed with the department. We have Dave and Wendy here, who are the leads in the UEC department. Within the paper, it sets out the go, no-go checklist, the quality impact assessment, and the crossover plan. So I'll just take any questions on that then, Chair. Thank you.
No, thank you very much, Helen, and thank you for everyone who's been involved in the very considerable efforts to get where we are. I would just like to reiterate a point Helen made of managing citizens' expectations as to what will happen on the 17th. The new building will not be a silver bullet to solve the issue of the ambulance stack and the ED delays, unfortunately, we're suffering from. That requires us to really get to the root cause of our flow challenges, to improve our discharges, and to get our specialist divisions to be supporting our A&D departments to bring customers through the acute quickly. So I would strongly counsel that we all manage our expectations, but in terms of risk management, I think this is a very sensible recommendation, which we have spent a lot of time on this morning. Glenn, anything you'd like to add?
Yeah, I obviously support the slight change in timing associated with this. Just one thing, I just ask if David, maybe you could just give us a little bit more assurance on the learning you've taken from elsewhere, because I know there's some other departments not far from here who've gone through a similar move, and I know you've been connecting with them.
Yeah, absolutely. Thank you, Glenn. So obviously we've been linking quite closely with the Trust Foundation Group, South Warwickshire as well. There's a few things that we've been looking at. So one is the priority pathway that we absolutely know we have to address, and we've been fortunate enough within this group that we can now work alongside partners from South Warwickshire to try and really expand that, because that is one of the key fundamental issues that is going to allow us to improve the experience of patients in our department. In terms of the move itself and going into a new ED, we've worked really closely with some of the team at Walsall. So we've been fortunate enough to go and have a visit, talk with their teams. They've shared their simulations with us in terms of what they did in the run-up to opening the new ED. And over the past 3-4 weeks, we've had some really great support from our intensivist team. So in particular, Laura Tullock has given up her own time. She's an ITU consultant alongside one of our nurses, Sophie Page. They've been coming in their own time, running simulations so that we could, any eventuality we could think of in terms of risk in that new ED, we've tested, such as, you know, if the lifts fail, if we don't have the right equipment, how long does it take to get someone across the bridge? We've been really thankful to them and to partners across the Midlands for any support they've given us in the run up to the new opening.
That's great to hear. That's the National Health Service working as it should be. Any other questions or perspectives to Helen? Or, as I said, but particularly for members of the public who are watching, we have spent a lot of time on this today. David, your hand's gone back up.
Yeah, I just, on behalf of myself, Wendy and Claire, we just wanted to go on record and thank so many people for the fundraising activities and the generous donations that people have made across Worcestershire. And we wanted to give the assurance that, you know, we're residents, we live here, our families are here, they receive care here. We want to do the best that we can for this place. And we want to make sure that all of that efforts for fundraising, you see a return on it. And you know, we owe it to the people, and we won't stop until we can try and make it better.
Well said, David. Very well said. So if you're not happy to approve this move of the opening date to the 16th of October, could you please raise a digital hand? Okay, duly approved. So we're then on to the integrated performance report. And Vicky, I believe I hand over to you.
Slight change, Chair, actually. We're going to go to Neil, who's as Deputy Chief Executive Officer. So we've mirrored the same format, Chair, as the other organisations in the group. Thank you.
No, that's okay, Vicky. So Neil, over to you.
Thanks, Chair. Yes, so as Vicky's just mentioned, this is the new format IPR. This is our first format of the Foundation Group. So yes, just by way of some highlights, and then I'll invite my colleagues to provide an update in their relative areas. So we continue to focus on flow as one of our key improvement initiatives, and some positive progress in the month in terms of the percentage of handovers completed within 15 minutes and the number of delays over 60 minutes. And I'm sure Helen will want to provide us with a brief in that respect. However, we do continue to struggle with some elective long waits, and again, Helen, I'm sure, will provide us with an update on where those are. In respect of cancer standards, we have some challenges in respect of urology and dermatology, and we're continuing to work with our partners around additional capacity and solutions for a longer term sustainable services in those areas with our ICB and our Foundation Group partners and tertiary providers. In respect of our financial performance, I'll touch on that in a moment, but again, you can see that we are off track. We are experiencing pressure, and in particular in respect of our capital programme, but I'll provide you with a more in-depth report further down. So if I could invite Helen to take us through the operational performance, please. Thank you.
Thank you, Neil. I just wanted to, so you'll see the narrative within the report, and so I don't tend to go through that in word for word. So if I could just take you to the pages where we have a number of the charts. So if we take in the first example, our ambulance handover delays for July. And it is fair to say that the organisation is still significantly challenged with the number of ambulance handover delays over 60 minutes. And we did see during July a slight improvement in that position. However, we know moving forward that position has not continued to improve. In fact, during August and September, that position has deteriorated. We've had a long discussion this morning, as you will have heard, as the board will have heard within the workshop, around the number of things that we are doing to try and improve that, and namely in the conversations that we've had around the opening of the new ED. However, flow is really important to improving the number of handover delay, reducing the number of handover delays that we have between 15 minutes and towards the over an hour, but also to improving our emergency access standard. And so, as I've said before, this is a priority for the whole organisation, not just for the UEC team. And so we have been working through significant numbers of standard operating procedures for assessment areas, increasing the same-day emergency care opening hours to maximise those opportunities to prevent admissions, but also to stream patients straight to those areas rather than those patients coming through our ED departments. We've had a number of no delays today events, which are mini-mades, which are being done within the organisation. However, we have a full MAID planned, which is a multi-agency discharge event planned for October, prior to the new move of the ED. I think the biggest challenge for us, but also quite excitingly, as Dave has mentioned, around how we're beginning to look at our frailty service and working across the group to really establish that, as we know we've been very challenged alongside that. And Glenn, you shared with us a chart earlier on in the day around the numbers of beds that are occupied by patients over the age of, and particularly over the age of 75. And it is fair to say that the organisation remains as challenged. And so really focusing on our frailty and how we can do better for those most vulnerable patients is a key priority for us. The other thing we need to be doing is reviewing the length of stay. And so what I will do as we move forward with the new format and report is for us to start to track a number of the things that we know we need to. And I think length of stay is a clear one. I think we should also then be reporting on our activity through our SDEX, but also significantly the numbers of patients that wait 12 hours in our EDs, because as we know, they are indicators for good flow, but also we know there's harm associated to those. And we also are starting in our development of a virtual ward programme, because as an organisation, we have virtually no virtual wards, and we have very, very limited virtual wards, and so a real drive to support that earlier discharge of patients out of the wards. So I'll just pause there to take any questions on urgent care before I move on to anything else.
Any questions to Helen? Simon?
Notwithstanding my senior moment a little earlier when I asked Glenn a question, there's a reference to insufficient alternatives for ED for patients. Basically, don't need to be there on the risk slide for urgent care, Helen. You've got any sort of mind's eye picture of what those might look like, what we're looking at that could be, in due course introduced that might help us there?
Yes, and actually Sarah is taking the lead for us as a system, as the SRO for the single point of access. So we've agreed across the whole of the system to have one point of access so that we can then stream patients directly to what those alternatives are, because at the moment our other clinical colleagues outside the organisation are thinking that the only place for patients to go is to ED, and that is not the case. So I didn't know if you just wanted to jump in on there, just to highlight the work that you've been leading on.
Yeah, thanks, Helen. So as Helen says, it's a single point of access for both access into the acute, so where there will be very experienced clinical triage, which will look at whether there are any services in the community or in the voluntary sector who can actually provide support better for patients and families in their own home. And if it's deemed that there's not those services, or the patient's clinical acuity means that they actually need to come into hospital, then we will have certain access points through our assessment areas, through our SDECs, so that we're not going into ED, waiting in ED for several hours before they then get in front of the right clinician, which may or may not be a frailty consultant. So it's early days, and we're just agreeing the timeline now, which will be in place by the end of next week, so that we understand what will come online at what point between now and December.
Thank you. And Richard?
Thanks, Russell, and thanks, Helen, as well, for the introduction into the performance part of the report. I was happy to hear that you said we need a little bit more information on length of stay. I also think we need a bit more information on discharging, and maybe also the amount of ward moves, given the experience we had from the patient earlier at the start of the meeting. But this is really important also to understand how we really remove the exit block from the UEC. Yeah, in the end, we need to see people leave the hospital as soon as possible, and currently there's nothing in the report. In general, I think the report is definitely moving into a better direction.
Thank you, Richard. And, you know, obviously length of stay and discharges are part of the same flow process. Helen, back with you.
Yep, thank you very much. So I just want to move on to cancer next, and the two key standards for cancer, which are the 28-day faster diagnosis standard and the 62-day standard. So take a 28-day faster diagnosis standard to start with. And so we know that the national standard is at 75% by the end of the financial year to achieve the FDS. And as of July, the trust standard is 70.4%, which is slightly above where we planned to be, but obviously not achieving the national standard as yet. But progress is good on that. I think the main challenges that we have are detailed in the report, but we do have some access to diagnostic challenges, particularly within urology and colorectal pathways, which often then give us that challenge in terms of making sure that patients are aware of their diagnosis within 28 days. So there's some actions in place there, particularly being supported by mutual aid from the foundation group, particularly around our LATPs, which is the local anesthetics transperineal biopsy pathway, and also through cystoscopy. We also we're expecting to see a business case coming forward within the next few weeks to increase the clinical workforce within the urology diagnostics, and so that should help in terms of creating some additional capacity. And there is also we've seen an increase in the demand for CT colonoscopy, which has been increased due to the changes in referral criteria. And obviously, we've talked about this before around having less invasive diagnostics rather than going for the full invasive diagnostics. So that has put some pressure on that. We also do have a challenge around dermatology, which I think the board is aware of, but we do have plans in place to try and mitigate those plans before we can reach a final solution with our colleagues at Wye Valley to provide a more sustainable dermatology solution. There are also some challenge around histology reporting, and you'll see, and I have mentioned that, particularly around the 62-day cancer target as well, mainly due to capacity in the teams in relation to reporting on histology. I'll just pause there for any questions on that, Russell.
No, great. Any questions or perspectives on this part of Helen's summary? Richard again.
Yes, sorry about that, but You mentioned dermatology, Alan, and I'd be interested to hear a little bit more about our plans there, given it's such an important element of our service.
Okay, thank you. As you are aware, we no longer have a significant number of substantive consultants within dermatology within the trust. This has been one of our fragile services for some time. And so the trust has already demonstrated how it can work well across the system, particularly with Wye Valley, when we looked at the fragile service of I think it was haematology. And so we decided to take a similar approach, or we agreed to take a similar approach with Wye Valley around dermatology. And so we're working with our Wye Valley colleagues for them to become the lead provider of dermatology services here, so that we continue to maintain dermatology services, but the Wye Valley, as they're able to recruit, will be that lead provider, and working through that model, because we've done that in reverse. From a haematology point of view, it is something that we do want to continue with our fragile services, working in partnership with Wye Valley about how we can support each other. What we do have in place, though, is a number of, because Wye Valley, it will take some time for recruitment to support in work within Wye Valley, and so we do have a number of options available to us by using some of the companies that we have currently use to support additional activity through dermatology. So we've got a number of outsourcing companies that we use, and we are also using some mutual aid from a number of other organisations that are willing to support us immediately. And we have also written out to primary care to ask them on the periphery to make sure referrals don't they to send their referrals in a different direction. And so we have made those organisations aware of that. So some of them will be bordering Birmingham, and some of them obviously already are bordering Wye Valley. So we are working through that now. Many of those things are starting to come into place already, and they will be the temporary fix until the Wye Valley model is up and running.
Thanks, Helen. We do need to watch our time a bit, but Glenn, quickly, because I think there are some learnings for us, aren't there?
Yeah, just quickly on that, the Wye Valley team have a really good teledermatology service, so there's an opportunity for that to be used. But also, just to make it clear, we're not suggesting that patients from Worcestershire should go into Herefordshire for their dermatology care. That will be delivered locally.
Thank you. But I think also we need to make sure the learnings as to how dermatology ended up being a fragile service, and how what we as a trust need to learn from that is important. Helen, anything else you wanted to cover, because we are conscious of time now?
So we've just got the 62-day performance, and so the biggest impact is similar, as I've talked through, the 28-day faster diagnosis standard, which is around dermatology, and some challenges in urology. So you'll see the details in there as board. So any questions on that, I will take. And then you can, I don't know, Vicky, whether you wanted to talk through the outpatient transformation work.
I can briefly mention a bit if you like, Helen. So we were invited to the Tier 1 meeting 3 weeks ago to give an update on our transformation programme, very much focused on productivity gains from reduction in DNAs and also reduction in new to follow-up ratios, as well as touching on some of those big ticket items that we need as an organisation to improve our utilisation and throughput. So, for example, we need to explore having a room booking clinic system, which we currently don't have. We've also agreed to be part of the Faster Further outpatient transformation work that Professor Tim Briggs is leading, and we're looking forward to participating in that programme. The strategic outpatient group continues to meet on a monthly basis, as well as doing a number of specialty deep dives with the first identified 6 specialties, which is providing some advantages in terms of getting underneath some of the really knotty issues that we've got. I'll leave it there if I may, Chair and Helen.
Super, thank you, Vicky. Thank you, Helen.
And then the last thing I just wanted to just say, Russell, was just around our numbers of patients over 78 weeks. So that number is set out in the report, just to say that as of the end of July, there were 43 patients waiting over 8 weeks and 3 over 104 weeks. And the actions to drive that number down and eliminate 104s and 78 weeks is written in the paper. And I've got a further paper later on around protecting and expanding elective activity that I can detail anything in there. Thank you.
Thank you, Helen. Yeah, I'd just like to put on record my apology to all those patients and their families who are waiting an inordinate amount of time to be seen. We are doing our best, as Helen's indicated, but we know if you're suffering in pain or a member of your family is suffering in pain, it's not good enough, and we're aware of that, despite all of everyone's hard work. Any questions to Helen? Otherwise, we'll move on to quality and safety. Okay,
yeah,
so
we like Jules and then Sarah to provide an update on quality and safety. Thanks, Chair.
Thanks, Neil.
So obviously you can see that the figures in the narrative there. From the Office of the CMO, the work we've been doing over the last month or two, reflecting some of these figures, we've identified through our SIs and our moderate harms and above themes that we need to be looking at delays in treatment and managing our deteriorating patients more effectively. As a consequence of that, we're going to utilise the opportunity presented by the new PSIRF, the Patient Safety Incident Reporting Framework, which is going live towards the end of this month. But we're doing a soft launch on that and taking the opportunity, obviously working together across the patient the quality and safety agenda to look at our 2-week wait pathways as a consequence of that, and see if we can take some learning out of that and get some rapid improvements on those pathways. We're also taking the opportunity to link the work from the identification of deteriorating patients in with our sepsis work. There's another opportunity with the EPR module in sepsis becoming available hopefully towards the end of this month. So we're reviewing all of our sepsis figures, taking opportunity to relaunch some of the work around that to try and improve those pickup rates in terms of screening and also the delivery of the sepsis 6 bundle. Fracture neck edema remains a focus for us. There is work going on with the division and the directorate in terms of an action plan to try and move some of those indicators forward and provide better care for that group of patients. Additional theatre capacity at Worcester has been worked up throughout last month to try and get some of the patients through a bit more quickly to theatre, and also a plan to deal with surge more effectively in that arena. So when we have more patients with neck edema come through, to work on surge capacity rather than average capacity. As we all know, averages are misleading in order to stop us having backlogs developing when we have more patients who suffer neck edema fractures come through. So that work is ongoing on the back of the action plan that came out of the division towards the end of last year. And as Helen has mentioned, fragile services remain something we're working in conjunction with our operational and nursing colleagues on, dermatology being the one, but also urology and audiology are areas of focus for us as well.
Okay. We'll get there together, Jules. It's a journey. Sarah, anything you'd like to pull out?
So what I would pull out is around that we're not compliant currently with any of the year-to-date targets for infection prevention and control. However, we were compliant within the month for Klebsiella and Pseudomonas. We have seen an increase in our COVID-19 outbreaks, and we do continue to follow our outbreak containment principles and the isolation of contacts, which does prove to be useful. Just a point for the board to note that in 23-24 there's a new metric which is being introduced to monitor our hospital-acquired pressure ulcers. And this is the total number of ulcers as a percentage of the emergency admissions. There isn't currently a national target that we can compare ourselves against or benchmarks. So we're using this opportunity to work across the foundation group to look at what our hospital acquired pressure ulcers are across the group to agree some local targets for this. But this is a measure of how well we are looking after our patients at the front door who are unfortunately having extensive waits on trolleys. And I'm really pleased to say that we had no hospital-acquired pressure ulcers that caused harm in the month of July, which is testament to excellent nursing care in that department. And the last point is around our complaints compliance target. So we did achieve 70% in the month of July, but the target has been missed for the 13th consecutive month. The challenge for this is that 130 complaints still remain open, and out of those, 62 of those 130 have breached the 25-day target, and that the surgical division are continuing to struggle, and they hold 53 of those breached complaints. There is a trajectory in place that's been agreed with the division for all of those overdue complaints to be actioned by the end of November. We've also put additional support into the division, which started today, around clearing that complaint backlog. And in addition to that, we're also looking at a specialist governance lead to go in and support the division for 12 weeks to review the systems and processes around governance and risk and to implement any changes. So I'm confident that we will begin to see improvements in this area, and certainly that backlog cleared by the end of November. So I'll stop there.
That's great. Thank you, Sarah. Thank you, Jules. Any questions or perspectives to Sarah or Jules? Simon?
Thanks, Richard, and thanks, Sarah and Jules. Just an observation, actually, on how the report was put together. There was a reference in there to where we sat in a regional comparator. I think it was with the septicemia on rolling crude death rates. Maybe something we could look at for other parts of the report. I think that's helpful. Just a brief mention every now and then of where we are compared to our peers would be useful.
Yeah, and I think obviously now Worcester Acute, part of the foundation group, every 3 months we'll be holding a full board meeting with colleagues in the foundation group, which pulls out lots of comparisons like that, Simon. And Karen, then we'll move on because we're running a bit behind now.
Thank you, Chair. Just a quick observation again on the style of the new report. Just very conscious that quality and safety has got the least number of pages. Every other area has a lot more pages. Now, there might be some sort of algorithm that suggests, but there's 2 pages on quality and safety, which is a little bit surprising. So just an observation, but as I say, I don't know if there's an algorithm maybe.
Glenn?
Yeah, we will add the fuller dashboard as we move forward with this, Karen. And thank you for all the execs for putting it into the new format. And we will try and ensure that each exec keeps to a similar size of report.
Self-evidently, the most important thing we do is to bring life safely into the world and to allow life to leave the world with dignity, and quality and safety are the absolute cornerstone of everything we do. We'll move on then if colleagues are okay with that. And in Tina's absence, Liz, what would you care to put out of the report?
So the 3 priority areas from a workforce perspective are about reducing our agency spend down to 6% of our total pay bill, which is in line with our ICS partners. So we have a challenging PEP scheme, which is going to largely help contribute towards that reduction. But also is our second area to improve is our sickness absence. So we have reduced our target further. It was 5.5%. We've reduced it down to 4%. So it's now in line with group partners. We've done a deep dive into sickness absence. And we feel that our sickness absence policy is fit for purpose, but we just now need to support managers in the implementation of that policy and actually using it on a day-to-day basis to manage sickness absence. And the third point is improving our job planning compliance. So we have been working closely with the divisions to identify what support's required. We're also working with group partners, that the Deputy CMO is linking in with South Warwickshire about the potential software that's used there, and whether that's something that we might want to use, because we want to make it as easy as possible for our medic colleagues to complete their job planning. They're the main updates.
Thank you very much, Liz. Questions and perspectives, Karen?
Thank you. I'm glad to hear you mention about job planning, Liz, because I think that's a massive concern, particularly in terms of how it might impact on our capacity and therefore elective issues. Just a query for clarification, because I'm hoping I've misread this. On page 75, you've talked about, or the paper talks about, the recruitment and healthcare support workers, and that we had 349 new starters in 1 month. Sorry, in 12 months, that would have been nice, wouldn't it? But in 12 months. But then we also had 241 leavers. I just wanted to be sure that the 241 leavers weren't from the 349 starters.
Yes, that is correct. We do have a higher turnover rate for healthcare support workers. It's around 16% at the moment, but it's certainly not as high as that. So I think that's just the way the report's been written.
So it's just overall, it wasn't of the new starters. Right, lovely, yeah. Thank you.
It would be good, Liz, just at one point to say to Tina to sort of unbundle that a little bit, so we did know how many people left within the first year or the first 6 months. I'll leave that with you. Colin?
Thank you. My question's on the same page. We talk about time to hire being reduced, which I think is great news. And I wondered, is that as a direct consequence of all the energy that's gone in the forward improvement process, and sort of linked to that, is that change sustainable, or have we got even more to go to see even quicker times to hire?
So it's twofold this. So we've had our recruitment business case, which is linked to a PEP, which has been an additional resource into the recruitment and medical resourcing teams. So we have got additional resource, but we are also implementing the forward improvement methodology, and we're just about to go into our 4th rapid improvement event. So it's a mixture of both. And because it's such an important factor in one of the value streams, we're really keen to utilise that metric more so that we can hopefully demonstrate those improvements.
I think, Colin, we've done an awful lot of work in the foundation group elsewhere on this, and I think there's probably more for us to go after. And then finally, Richard, because we are running late now. Richard?
Yeah, I'll keep it short. My question is also related to consultant job planning. I'd like to understand when we think we're going to meet our target, because it's so vital to meet our productivity.
Yes.
I haven't got a date in mind. I mean, I don't know whether Helen, because obviously I know you've been working with the divisions as well, whether you've got a date in mind.
Liz, just before I invite Helen in, one of the things I learned really early on in my life, which was you being very wise there, which is if you don't know the answer, say you don't know the answer. Never a problem of this ball, just so that everyone gets used to my style. I don't have a problem if you don't know the answer. I'd far prefer that, and that you're straightforward, come back to me or come back to colleagues with the answer, rather than blag it. We're too old to blag. Helen, do you know the answer? Do you want to come back on it?
No, I'm not going to blag it either. I'll come back to you.
Wise, yeah, very wise. Okay, we'll move on then. Thank you, Richard. We'll get the answer and we'll pop it onto the action log. So we'll move on then to how all this looks in terms of the money. Money's still looking very difficult. Over to you, Neil.
Yeah, thanks, Chair. So at the end of month 4, we were adverse variance to plan in month of 1.7 million, which brings us off track, overspent against our plan by 6.4 million year to date. Hope the board finds it helpful, but I've put a summary table in there of the key drivers of the variance, and I think it highlights the three main areas that are driving that variance. So 1.8 million is due to timing. So we had some late additions to the plan as a consequence of some late negotiation of our settlement with the ICB. So you'd expect those variances to come back in line as we progress through the year. There's some exceptional unplanned items, as I'm calling them, largely driven by industrial action and some backdated pay awards, again, that we hadn't foreseen at the time of planning, 1.2 million. And then the remaining balance, 3.4, is really what's driving our our run rate on a regular basis so far this year that we need to really get a grip of and get underneath the skin of. So we're off track in respect of income. So within our plan, we'd assumed an additional £20 million of elective recovery fund income. You can see there that we're between £1 million and 1.3 million off track in respect of our income year to date in respect of the pure ERF elective activity component. And the other main driver there that you can see is around PEP. So we're off track in respect of our PEP by 1.4 million at month 4. And again, I'll come on to that in one of the slides. Capital, as we've spoken before on a month-by-month basis, is severely challenging for us as a consequence of the overspend on the UEC build. And this year's programme, the 1.7 million that we had in respect of the UEC is estimated to come in at 5.5. That is largely driven by the VAT reclaim that is currently being challenged. We are appealing that at £3.5 million, but again, we at this stage, I'm just reflecting the risk in the position. In terms of cash, end of July, cash balance was 11 million. It's 4.4 below plan. Not an issue right now, but clearly, if we were to continue the run rate as we see there, that will cause us a challenge as we progress through the year. So over to the if I can just focus on the productivity and efficiency slide. Just looking at our maturity matrix, you can see there that it hasn't progressed significantly in month 4. So we've done a couple of things. We've devoted more senior resource to get underneath the skin of that. And we're working with our executive scheme leads and senior responsible officers to get to a point of a forecast for the end of September. We're also reforecasting the end of year for the whole of our I&E position. We'll bring that forward to the Finance and Performance Committee at the end of the month. But certainly we need to drive forward the maturity and make sure that the schemes as they have been outlined are progressing as planned. So you can see there in the month the 1.4 adverse variance to plan. But we have taken additional senior resource on board to drive that, but we're not seeing the benefits come through that we had identified at planning stage. The other key driver is agency spend, important focus for us because, again, it does underpin some of our productivity and efficiency plan this year, and we have invested some significant resource into the recruitment team in order to drive some of this, and we're not seeing those benefits come through at this stage. So July, our temporary bank and agency spend rose to 18.5%. I think at that stage, some of it may still be linked to industrial action, although going forward, of course, I believe that is now we're not able to cover posts under industrial action from agency using agency. But clearly, there you can see still a significant interim cost associated with bank and agency that we do absolutely need to start making some inroads into. You can see our agency has come down, but our bank is going up. And overall, we're not seeing that significant improvement that we would hope to see as part of our productivity and efficiency plan. Back to you, Chair. Thank you for any questions.
Yeah, we are now running late, but any questions to Neil? Obviously, we've got a lot of work to do, but I know everyone's working in that regard. Richard?
Yeah, well, we'll ask a couple of questions next week, but the big thing is some of the whys behind what we see and what you've explained, Neil. And the one that I'm particularly interested in is the one that's related to, we've done a significant amount of insourcing. We don't see the effect of that on reducing our waiting lists, but we equally don't see any effect of that in terms of the income we expected. It feels like a double whammy. I'd really like to understand a lot more why this is happening and what we can do about it.
Absolutely, because it's worst of both worlds at the moment, arguably, Richard. Neil, do you want a quick answer here, or take it up next week?
I can take it up next week and provide a very quick answer from the financial perspective. It's largely at tariff and above, Richard. That's the pressure we're under. That pressure's being brought to bear from NHS England around achieving the reductions in the backlogs and the targets. Maybe Helen wants to comment from that perspective. But from a financial perspective, there's no benefit because it's largely at tariff or above, unfortunately.
Okay, let's do a proper deep dive next week, but Helen's nodding. Thank you, Richard. Okay, so we are running a little late. Really good, given that's the first time we've done the integrated performance report. Thank you, as Glenn said, to everyone and all the efforts that's gone into that. Vicky, I was in anticipation of you, so I apologise if I was presumptive.
No, thank you.
The committee assurance reports. And the first is the Finance and Performance Committee assurance report. Anything, Richard, you wanted to pull out of this as committee chair?
No, we've essentially highlighted the main issues that are reflected in the report as well. So I think leave it there, Russell.
Okay, thank you. Any questions to Richard on the detail of those reports? Okay, so Julie, on the Quality Governance Committee assurance report, anything you wanted to pull out?
There is, I'm afraid. We've talked about the Letby report. It was an intense meeting, but we have had an issue with bed cleaning in view of our C. diff issue. And we had a proposal brought forward some years ago that we've not resolved. I think Sarah's come in and looked at it anew with Scott. And so they're going to bring this to board next time, a full report on how we're going to cope with bed cleaning across the trust, because we haven't had a proper systematic way of doing this, which is a big risk for C. diff. I won't say any more about that now. We've also had an issue about the kitchens and the cleaning, which Sarah's going to update us about later on. So I won't go into that now either. The rest of it is as read, I think.
Thank you very much, Julie, and thank you and all the committee for their diligence. Any questions to Julie? Okay, so we'll move on then to people and culture. Karen, anything you wanted to pull out of the report?
No, I think we've covered most things. The only thing to very quickly say is it talks on page 91 about that we're looking at some new icons, and that goes back to the whole principle we've been talking about already this morning, which is about streamlining the explanation and helping our staff understand some of the tools that we've got in place for them better.
Okay, that's great. Thank you. Any questions to Karen? I have to say, I do love the Barbie pink colours on my board pack for the People and Culture Committee report. Whoever chose that, well done. So then we'll move on to the Protecting Elective Capacity Self-Assessment. Helen, over to you.
Thank you, Russell. So to maintain pace on the meeting, I'll take the paper as read, and that the NHS England wrote to all chief execs requiring a submission of board assurance against 4 areas, which were validation, first appointments, outpatient follow-ups, and any support required. So the paper sets out where we have assurance against those standards, and there are 3 areas where we have partial assurance. And so in terms of the first area for partial assurance, which was around the validation and the to regularly revalidate all pathways at 12, 26 and 52 weeks. And so we do have plans in place, well, plans in fruition, I would say, to be able to address that, but they're not fully in place yet. And that is a challenge to regularly revalidate the waiting list every 12, 26, those patients at 12, 26 and 52 weeks. And so that's the item there that gives us partial assurance in that standard. And the second one was around the board has received a report on the clinical risk of patients sitting on a non-RTT cohort. And the issue in relation to that is in bullet point 3, that a piece of work is required in relation to patients on active monitoring, because there are a total of over 51,000 patients on active monitoring. And so for a clinical and validation piece on that, that will take a considerable amount of resource to do that, although we are aiming to move towards that, but we're not fully assured on that piece at the moment. And then the final one is in relation to the outpatient follow-ups, and that's and we can't reduce all of the outpatient follow-ups to the required level yet because of the large numbers of patients on the non-RTT pathways as described in the previous point. And so until we've done that clinical validation piece, it's going to be hard for those patients that are on active monitoring for us to reduce those the number of follow-ups. So again, those two pieces go hand in hand. So I'll just take any questions on that, Russell. And then I think we're asking the board to delegate the final sign-off of the self-certification to the Chief Exec and Chair for the form to be submitted to NHSE following any additional actions as a result of the discussion here.
Super, thank you, Helen. So we're partially assured on two and assured on two others. Questions and perspectives, Colin?
Thanks, Russell. Are there any consequences / implications of only reporting partial assurance?
It would probably be an action plan, Colin, to address the partial assurance, but I'm sure Glenn will come in back on that.
Glenn?
Yeah, I mean, this is more for our benefit in terms of validating waiting lists and being on top of where we should be. But Helen's right, there'll probably be some further assurance required as a result of not giving that assurance.
Yeah. And any other questions or perspectives? So Helen was recommending delegated authority to Glenn and I to final sign off on the final version. If you're not happy to provide that, please raise a digital hand. If you're not happy, please raise a digital hand. Okay, so I take that as read. Thank you. Confused me slightly there, Richard. I was getting worried. So we move on then to the Complaints and Powers annual report. Over to you, Sarah, please.
Thank you. So the annual report details the key performance and activity for Complaints and Pals during 22-23. I'm taking the report as read. I'm not going to go through it in detail, but just really to highlight to the board that a key priority in 23-24 will be for the team to focus more on themes and to really truly understand what patients and families are telling us, and then using this information to drive the quality improvement agendas which are required. The second focus will be on standardising how the complaints process is managed across each of our divisions, and the corporate team will be supporting the divisions to do that. And lastly is a focus on improving the quality of our first responses to reduce the numbers of complaints then which then emerge. So I'll leave it there, but happy to take questions.
Sorry, Sarah, perfect, thank you. Any questions or perspectives to Sarah? Karen?
Thank you. Sarah, as you'd expect, I'm going to ask about surgery again. I know that you said you're assured, so I'm sure we'll come back to that. But I was conscious on, I can't find the page now, page 112. It talks about the surgery only responding to 47% of their complaints on time, but also women's and children's 38% on time. So I don't know if I've missed something, but I'm guessing we've got more confidence in women's and children's, or that's been sorted.
Okay, so from an assurance point of view, Karen, for surgery, I'm assured that we are putting some very experienced support into the division in order to do systems and processes and to support them to clear their trajectory by the end of November. The women's and children's, they have some complex complaints where they prefer to meet with their families, which adds time on their complaint responses. I have met with them and I am confident because they are out of date on some complaints now. So they kind of do struggle from time to time, dependent on the complexity of the complaints that they're dealing with. I do know that we have got Justine. I don't know whether you want to add anything, Justine, as our direct midwifery.
Yeah. So we do have fluctuations in when we receive complaints, Karen, and unfortunately quite recently we had a little flurry altogether. As Sarah's outlined, quite a lot of our families do like to meet us before we actually send them a complaint response, but also if there's an investigation being undertaken as well, they like us to complete the investigation and then respond to them in the complaint based on the outcomes of those investigations as well. So you can see it's really difficult then for us to adhere to a 25-day timeline.
Yeah, I think the key thing, I'm sure Karen would agree with me, is to do it with empathy and sympathy and at the pace which works for the family. Any other questions or perspectives to Sarah?
Can I just add, Russell? I think you're absolutely right that it is about the care, compassion and the empathy, but there's also, we do have a option of, if it's a complex complaint that we review at the beginning, that we can extend the time scale, so away from the 25 days. So I think maybe that's something that we need to look for some of the women's and children's complaints.
That's great, thank you. Any other questions or perspectives to Sarah? Karen again.
Sorry, just very quickly. I was very struck by the fact that our biggest theme is clinical treatment, which in my experience is quite unusual. It's normally always about behaviour or attitudes or something like that. And I just wonder how much we're reflecting with the divisions, what have you, that actually if some of the issues that we've already talked about today in terms of performance were addressed and improved, we might not be getting so many complaints.
But that's a really good point, Karen. Just an observation. As soon as we move to the new finance and performance structure, we'll be having those type of discussions and this type of data in those meetings where the divisions will have to dig into it themselves and answer, and it will be a great opportunity for NEDs to hear their response in that granular detail. So, anything you wanted to add to my reply?
No, I absolutely agree with you, Russell. And this is part of the report. This is, I mean, I'm new into post, but I don't think that we are understanding, Karen, enough about what is coming through in our complaint responses, and that informing our work as we move forward. But as Russell's outlined, that will certainly be addressed in the meetings moving into the new world.
Okay, thank you, Karen. So if you're not happy to approve this report, could you please raise a digital hand? Okay, duly approved. Thank you very much. Standing orders for approval as well. Rebecca, over to you.
Yes, thank you, Chair. This paper sets out the technical changes to the Trust standing orders, which in effect enacts the board's previous decision to join the foundation group. The changes are outlined in the paper. They're set out and make sure that that we're compliant with the various regulations. The changes have been through Audit and Assurance Committee and therefore have had the oversight of our internal and external auditors and have also been subject to legal review. I think there's a broader exercise as the foundation group arrangements develop in terms of looking at the arrangements across the various trusts in the group. However, no further changes are proposed at this point. I'll take any questions.
Thank you, Rebecca. Any questions on the standing orders? So just for the avoidance of doubt, and one particular thing which is a bit different in them in terms of the vice chair appointment, but just so that it's in line with what I'm used to elsewhere. I assume whilst it's obviously at the approval of the trust board, it's at the recommendation of the chair.
Yes, absolutely, Chair. So the Chair would present to the board the various appointments, including the Vice Chair and that of the board subcommittees. We'd usually do that via the Chair's report, and then that would be approved by the board.
Okay, super. Thank you very much, Rebecca. So if you're not happy to approve the standing orders, could you please raise a digital hand? Okay, super. And so I think we're on to our final item, which is the safest staffing report. Over to you again, sir.
Thank you. So for nurse staffing report, The board's invited to receive assurance that both paediatrics and neonatal units were deemed to have been safely staffed to the RCN and BAPM levels throughout July in 23, and staffing on all of our adult areas were also safe throughout July. The BMA strikes that took place throughout July, pleased to say that there were no incidents or safety concerns raised from nursing because of this action, and that we have commenced our summer acuity and dependency review, which started at the end of July. We have already heard around our registered nurse and HCA vacancies and recruitment in a previous paper, but again, from joining the trust, I do feel that we could actually maybe be a little bit more ambitious with our healthcare support worker targeted recruitment, and we are looking to put on recruitment days over the weekend to be interviewing and offering and getting people through their recruitment checks extremely quickly. So I'm hoping to finalise that plan over the next few weeks with the teams. You'll see in the paper that the use of surge capacity around our UEC and A&E corridor continue, and that we do rely on the use of temporary staffing solutions for that. And just to note that in May 23, there were 41 insignificant or minor incidents reported around nurse staffing absence, but no moderate or significant harms. And just a point to note, around the urgent care division are carrying the highest registered nurse vacancies at 61.38 whole-time equivalent, but as we've heard, they will be fully staffed by the end of November. So I will stop there, but happy to take questions.
Should we do Justine as well? Justine, do you want to cover off midwifery?
Yeah, thank you, Chair. So this is the Safe Staffing Report for July with an assurance level of 6. You'll see that there's been some reduction in the performance around sickness, and it has actually slightly increased with midwives. It's down slightly in MSWs, but the turnover has increased. That's due to some people who were on long-term sickness having now resigned. Unfortunately, whilst we did meet the KPI of 100% of women receiving one-to-one care in labour, we were not able for the first time to meet the supernumerary status of the shift leader, and that has adversely impacted on our CNST compliance for this year. You'll see I've outlined within the report the 6-monthly tabletop birth rate plus, which confirms that we have no additional funding. Some of you will have noticed in there that it looks like we are over established, but actually that's the percentage of leadership posts that we require now to actually run a maternity service safely and meet the requirements of Ockenden, etc. Also within the report, you'll see that 81% of the time we met acuity on delivery suite without having to do any deployment, which is always a good place to be. There were 4 medication incidents, only 1 that actually led to some harm, and that was a lady who had an anaphylaxis following receipt of penicillin. It was an unknown allergy prior to that event. In terms of our vacancy, you can see there that there are high levels of vacancy within maternity services. We have 21 whole-time equivalent midwives joining us across September, October and November, which will give us something around a 4 to 5% vacancy once they're in post. We have had some significant onboarding positivities there, and we're not expecting any delays in those people arriving, which is really good news. And we're now really focused on our support workers. As you've heard in previous reports, retaining support workers is really difficult, and in the last month we've actually substantively employed our practice development midwife for our maternity support workers, and she's working with our HR colleagues as well to start to focus on retention and continuing to develop that workforce. So that's all positive. So I won't say any more at this point, but happy to take any questions.
Thank you, Justine. Thank you, Sarah. Any questions to Sarah or Justine on the safe staffing report? Okay, so I think then we are on to any other business. Simon, is there anything, as a Health Watch friend, partner, anything you'd like to comment on?
Not at this time. I don't know. I just came back from leave today, so I didn't get the opportunity to even read the board papers, I'm afraid, before I joined the meeting. And I'm sorry for being late, but I also managed to onboard 2 new directors today, so a big success for us, I've got to say. The difficulty in recruitment. I look forward to meeting you both, you and the CEO, at some time in the future, and continuing the relationship. I think the good relationship we've built with the Trust over the last 10 years.
Super. Well, thank you, Simon. Hope you had a good break. Any other business from any colleagues? Please raise a digital hand. Just one from me. This is Rebecca O'Connor's last board, I think, with us. She leaves at the end of this month. Actually, Rebecca's leaving on the day of my birthday. But Rebecca, I'd just like to say on behalf of the board, previous chairs, previous NEDs, previous execs, thank you very, very much for everything you've done to help things run as smoothly as they do. You will be missed, but we wish you well in your new job, and wish you every happiness and success. Take care. Ladies and gentlemen, look forward to seeing you at our next board, which will be announced in terms of date in due course. So if we can end the live streaming now, Rebecca, because I think we stay on this line for the charity trustee meeting. Is that correct?
Yeah, that's correct. Thank you, Chair. We've just turned off the recording. Thank you.
Super. So, Simon, I think you're chairing this, aren't you, or is that my imagination?
No, it's over to me. The report is as tabled. It's a fairly brief report this time. I'll take it as read and happy to answer any questions.